E ngā mana, e ngā reo, kei te mihi ki a koutou, e hui hui tahi nei te whakarewatia tēnei kaupapa whakahirehire. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Whakataka tahau ki te uru, whakataka tahau ki te tonga, kia mākina kina ki uta, kia mātaratara ki tai, e hia ke ana te atakura, e teo, he huka, he hauhu, tihei, Māori ora. Morena, everybody. I understand we've had a few glitches, people getting on, but hopefully people are able to join us. We've got a very busy agenda today, and so I won't hold anybody up. I would just like to introduce Andy Inder, who's the Director of Ageing Well in National Commissioning in Whatu Ora Health New Zealand. So, kia ora, Andy.
Kia ora, Teresa. Thank you very much for the intro, and thank you everybody for turning up and being our crash test team to go through our engagement pack today. We may have some teething problems, I'll warn you in advance, but the team's been working really hard on getting things sorted. And so this is the first chance for us to sort of go through with a large group of people and outline how we're going to approach engaging in terms of designing the system and getting your feedback around how you would like the system to work as users of the system. And I know a number of you also have loved ones that are users of the system as well. And so our goal today is really about designing the aged care system in a way that works together to provide people-centred care, improves outcomes, and promotes independence. It's not about how much we pay a caregiver, how much we pay an ARC facility. But we think we really need to start around how we want the system to work together so we can provide really good pathways of care for people when they have a need. And we know on the evidence base we've got today that there's evidence-based models that make a much better impact on the care of people, and we're not necessarily using those everywhere. So we'd like to take you through a pack today. But I think before we sort of go on to how we're going to design the future, I always think it's really good to sort of recognise our system delivers an awful lot for people today. And so we have around about 35,000 people in over 670 care homes across the country. And despite some of the things we hear in the media, the number of beds we've got is slowly growing. I accept that we're going to run into a challenge soon because of the demographic challenges we're facing. At the same time, we have more than 80,000 people receiving home and community support services. For over 65s, the enrolment is well above the national average at around 96%. And again, we have challenges around access to primary care services in many places. Generally, older people have really good access to medicines in New Zealand. In some cases, I worry a little bit that they've got access to too many medicines and we prescribe them things that actually do harm or have unintended consequences in some way. And I think we need to do better on that front as well. And then there's an awful lot of care provided in hospitals for older people. And so they use around about 1.25 million bed days per annum, which is about 55% of our national hospital capacity. And at times, I think, and the feedback I get is they get stuck in hospital for too long, and we don't have really good pathways to get them back into their living setting in a way that's supported, because when you're sort of medically stable, the hospital is not necessarily the best place for you to spend a long amount of time. And so I think we need to do a little bit better on that front as well. But this is our chance to sort of work through all of those details and think about how we want to design the system and how we'd like it to work in the future. So some of you will be thinking that we've been here before. And look, I think we probably have. There's been a number of reviews done in the past. there's been a stack of recommendations that have been encompassed in those reviews, and they haven't necessarily been implemented in the time we've got available. I think we're at a really interesting place for our health system, because there's really broad recognition across government, across funders, across our communities and our provider networks, that actually, if we really need to take some action now. And so I recognise that we have been through this review process previously, but I think we do have a general consensus that we actually need to take some positive action on the system. Some of you will have seen the aged care review that got released a little while ago. It probably also contained no great surprises for you. And so it did sort of outline that while our funding generally covers people's operating costs, it doesn't provide sufficient margin to invest in the businesses. And that was true across ARC and home and community support services. That access across the country is really variable. And there's some access issues for priority populations and rural populations that are worse. And in some areas, we don't really, I think, fully understand the disparities in access. And I think as part of this engagement process with communities, that might bring some of those challenges to light. But I think we also need to do a better job on our side of the fence in terms of matching up the data and tracking some of these journeys through the health system as well. The aged care system faces workforce pressures that are similar across all of the health system. And the feedback I get is, while that's from a nursing perspective, the pressure on that is eased, we're still going to have to focus on the workforce, both in terms of registered and unregistered workforce, and really proactively build that over time, because they're going to become more and more important as we move towards sort of 2040. We want to make sure that there's better access to support for carers. And again, that's one of the things that's really variable across the country. And we want to make sure that we've got really good funding models that distribute funding to providers in a way that reflects the complexity and the challenge of looking after some people that have higher needs. So in our current environment, I think, again, there's probably no great surprises when we talk through this. We've got an ageing population that's coming through. So over 85-year-olds in New Zealand are predicted to double to almost 200,000 people in the next 15 years. And so that's while our underlying population growth is forecast to be at about 11%. The relative portion of people over 65 and over 85 is going to grow really significantly. And so we need to plan for that, and we need to have an idea around how we're going to meet that future demand, how those pathways are going to work, and how we're going to partner with our hospital colleagues and our community service providers to ensure that we've got really good pathways of care, that we're providing the right level of support, and that outside of hospitals, we've got the right access to primary care, both in terms of general practice services and medicines management, so that people can confidently stay healthier at home for longer. We're sort of really fortunate in New Zealand, whether this is by accident or by plan. We've actually got one of the best well-researched evidence bases in terms of the types of models of care that make a difference to older people. And so if you look at restorative care models that look at adapting the care that is provided to older people in their homes over time, early supported discharge models where they operate, we've got really good transition to care services in some parts of the country, and short-term ARC care models that we know actually keep people out of our hospital settings and make their return back into home settings a lot more sustainable. And then in some places in the country, we're starting to get better kaupapa Māori delivery of services that are more whānau based, And I think that is starting to come through in some of the numbers when you look at the level of home and community support we're providing Māori populations. Generally, they receive about double the number of hours that non-Māori receive in terms of home and community support. And I think that's reflective of ARC settings not necessarily being the right cultural fit for them. But what I'm unsure about is whether we're providing the right level of support to those people, and that's one of the things that we're going to have to work through slowly over the next couple of years. So we do have a whole lot of strengths to build on. I think one of the things we need to think about is how we fit all of that together. And this is sort of our draft around how we think things could work. So if you start on the left-hand side of the model, we've got hospitals and specialist services around the country and primary care where are our response mechanism to people being acutely unwell. The transition between being acutely unwell and returning to your living setting, whether that's living at home or in an ARC facility, is not well planned in some areas and not well managed. And again, I think that comes down to the mix of services. If you think about our ARC facilities, we fund those in a relatively blunt way, and we don't fund for the additional cost of people moving into restorative care facilities or getting respite care. And I think we need to move forward on that. And I'm really interested in people's feedback around how that might work. I'm also really interested in the living at home and how we can support that for longer, ensuring that we've got really good carer support, that we've got restorative care options, and that people who are do have a functional need, we're supporting that over time. And then in those living settings, I'm really interested to understand what an enhanced primary care model, a modern medicines management service, and the other community services that we provide, how we can sort of provide the right care and the right integration of care across those services to keep people in their chosen living setting healthier for longer so they don't end up in hospital. So this is essentially our straw model going forward, and we're really keen to sort of unpick this with you today as we go through it. So in terms of key drivers, we've got the Whatu Ora legislation sitting in the background. We know we've got some best practice models of care that are already delivered, and we've got some standout ones. So the START program in Waikato, where they have planned restorative care that's supported by allied health providers in people's homes and in ARC facilities. And that demonstratively shows you have shorter hospital stays and you have fewer future hospital admissions. And when we can show that through our evidence base, we really want to, I think, make sure that that's available for people across the whole country. We want to tie our approach back to the healthy aging strategy, because I think when you read through the healthy aging strategy, it's still fit for purpose. And, you know, that great work that's been delivered across the system that to support that strategy, we really want to make sure that we have a plan around how we can make that support more consistent across the country. And that's basically why we've invited you here today. So we want to hear back from you how you think some of those ideas will work, where you think we need to improve things, and the sort of alignment of the different services across the system, where that's working and where that's not working from a personal experience perspective. So again, just coming back to our goal for the day, this is really about system design. We want you to focus on how we can put the system together in a way that meets our needs. And then once we've got that high-level plan, that allows, you know, me and my team to go through the proper modelling of that, to look at how we fund that properly, and then to work with what we can do within our
all good. All right, I'll start again. So There we go. All right. So we're going to get into our kind of core activity today, and we're excited to engage with you on this, as Andy mentioned earlier. So how this session is going to work is we're going to get into breakout rooms to discuss that aged care system model through 4 different lenses. And the first lens we're going to look at is supporting to stay at home and returning home. We're going to look at aged residential care. We're going to talk about support for our carers, and then the GP and pharmacy layer as well. And for each of those 4 topics, we're going to have 3 different future state statements describing what that ideal future aged care system could and should look like, with one overarching question, which is how might we achieve this ideal future state system? We're going to go into some randomly assigned breakout rooms for an hour. That's 15 minutes per topic. I know it's early in the morning for math, but the good news is that we'll have a member of our national team in each of the breakout rooms to help keep track of time. They'll introduce themselves in the small groups. And what we'd like you to do is reflect on the statements and the prompting questions in the groups and take notes. I think you've done this in the past, where you share your notes back to the leadership group. And if one of the topics or one of the statements isn't relevant to you or your role or your organization or your line of expertise, that's fine. Share what you can, write down some follow-up questions, and contribute where it's most relevant to you. In addition, we'd like each breakout room to nominate someone to share back at the end and their thoughts in a plenary discussion after you've gone through all 4 topics, and I'll help guide the discussion at the end. Those notes will be useful for that plenary discussion as well. And if that weren't enough, our facilitators may also be taking notes on a digital whiteboard, which they'll share the topics on in the session. And then those will be shared in the breakout rooms. We'll work with the leadership group to collate all of these notes to feed back into our wider engagement program. Shireen, have I missed anything from the note-taking perspective?
No, all good, Kelsey.
Cool. All right.
Just to remind everyone, you need to send your notes from the breakout rooms to the New Zealand Dementia Foundation, and just use the link that you got your reminders on. Okay, thank you, Kelsey.
No worries. Now, one more thing before we jump into our breakout rooms. We know that this is a complex set of topics. We're redesigning a system after all. And so 15 minutes is probably not enough time to do each topic justice, especially in groups. So after this session, we'll be sending out a survey to collect additional, more detailed information, giving you time to give your considered feedback and ideas after things have kind of percolated for a while. So the aim of our discussion today is to get some big themes, identify some big boulders that we may need to shift and align on to make sure we're addressing a future state we're all collectively going for. We had one question. Catherine, I see your hand is raised.
Yes, thank you, Andy. Thank you, Kelsey. I mean, I guess I have 2 questions, and I think they feel like important contextual questions before we launch into those small groups. So the first is that it wasn't clear to me, looking at those examples that you used, Andy, how the chronic and progressive conditions fitted into that. So some of those best practice examples were kind of transitionary, and so I think that it wasn't clear to me whether you were interested in the chronic and progressive. And that's important for this conversation because this is the Dementia Network, and neither of you have mentioned dementia. And so we have a particular interest in how dementia, how people living with dementia, and how the Dementia Mate Wareware Action Plan is reflected in this new model.
So absolutely interested in both sort of transitionary services and people that have chronic conditions as well. And, you know, I think what we've tried to sort of frame up in the wiring diagram is that, you know, these people have living settings, whether they're acutely unwell, whether they're chronically unwell, and we need to make sure we've got the right wraparound services for them. And that should be to some extent agnostic to the condition, but I do accept that we have different care standards for people that may have dementia versus people that might have another chronic illness like COPD or something like that. But I still think in terms of how we sort of move services together, it's a relatively generic problem, and we need to make sure we've got the right support for people to provide the right level of care. And I expect that from your group, we're going to get different feedback from a group that we might have that is focused on another group of older people. And I think that's fine. It's Kelsey and the team's job to sort of bring all that feedback together, and so we can actually try and work out a way forward to meet the needs of, you know, the whole of the older population. And I do accept that, you know, the numbers of people with dementia that we're going to have to be looking after are going to grow as well with the older population.
So I'll just make sure everybody's come back together. How were those conversations? Was it enough time to get through everything? No, of course not. Kind of. Oh, okay. I got some kind ofs. That's good. That's good. Look, as I mentioned at the start, the real intent of this was to start the juices flowing, start to percolate, start to share some of the initial ideal state thinking that we have, so that we're all heading in the same direction. So we're all aligned on where we want to get to, and we have a really good understanding of how far away or close are we to achieving some of these things. In our group, we talked a lot about how things are kind of interconnected, and you can't solve one without solving the other, and making sure we've got a kind of diversity in there. These are all great things for us to take forward as we move through and improve this model and build a plan for action. What we're going to do now is, I think, hopefully everybody has a nominated representative from their room. Is that correct? Yes? If so, then we'll have everybody else turn their cameras off, and we'll just have those nominated representatives have their cameras on. And I'm going to ask us to kind of share back some of the things that we talked about. Susan Noseworthy, did you have a
Susan Noseworthy has to say that she neglected that step in her facilitator role.
Oh. And
person.
in my room, no one wanted to put their hand up, so I might have to volunteer some people to respond as we kind of go through these things.
Or Susan could randomly select somebody.
Yeah, maybe Susan could.
We had a voluntold member of our working party, Catherine.
Voluntold, right.
Yes. Army volunteered I was, but, you know, I guess that works.
Well, what if we asked Daryl or Karen to do it from room 1? Would that be okay?
Well, there'll be some pretty pointed questions and things like that. So hopefully we can lean on some of the thoughts that you have. The folks that are that will kind of be speaking, keep your cameras on. Other folks can turn their cameras off so we can focus on those people. And we'll start kind of just to think about, maybe across all of the topics, what are some of the key themes that emerged from your discussions that were common across all 4 topics? For example, in room 6, where we had a lot of talk about, you know, making sure that we're supporting people early on in their dementia journey, so we can keep them at home longer, keep them mentally well longer, and making sure they're well supported, so that we don't put higher pressures on the other parts of the system down the line. That was and that we can't fix one piece of the system without considering everything else on the system. Was that something that came up in other discussion groups?
Hi, Kelsey, Kristen here. Yep, I was from room 2. That was a theme, and one of the key drivers that was identified for that in our room was better use of ACP, advanced care planning, that would facilitate those conversations. So that was definitely a theme for us. And also just a general theme around being more joined up between GPs, pharmacies, secondary, primary, and NGOs. Just, there was a general theme coming around about that, about missing people having different aims in ARC that weren't being met by, for instance, a physio coming into ARC and being told, no, you can't work on that person who's having respite, but you can work on that person who's residential. So just a big, when it would be very beneficial for the physio to be working on a person with respite.
I think from our group, oh, sorry, Kristen.
That's it.
We were in breakout 3, and that point came up consistently in our group as well. We felt that the model and the way it was presented didn't highlight how important that early stage of the journey was sufficiently at all. And we talked a lot about how people get into the system and those early things around even knowing that something is wrong. So health literacy and knowledge, knowing where to go to get help, being able to get a diagnosis when you need it, being able to be referred readily into services that help you preserve and maintain your function early on, and well before some of the things that were highlighted in the model, like personal care and home help, ever kick in. It's those earlier things, and those, of course, are about those interfaces largely between the community sector, NGOs, and primary care.
Yeah, we talked a little bit about that in our room. Prudence, were you going to say something?
Yeah, I was just going to say, I have no idea what workshop group I'm representing, but I am the note taker. I was arm wrestled into it, but that the disconnect was that Kristen was raising was definitely a theme throughout all of the topic areas, that there's no that we're far from any ideal where we're integrated and all connected amongst one another. And there was a lot of discussion around the fact that this is because dementia isn't really mentioned explicitly throughout the model, and that there seems to be a leaning towards the funding lens of it in a restorative approach, which goes against the grain of living with dementia. Then when we're talking about a system that's more flexible, the flexibility needs to be progressive with the stages of dementia and living with dementia. And so the lens needs to switch from a government lens of who we fund and where and where are the gaps in our funding, to, oh, I've got dementia, what's out there for me so that my quality of life is maintained at whatever stage I find myself at in my region. So those were the themes that sort of came across to me in our discussion.
Thanks, Prudence. Debbie, you've got your hand up.
Yes, I was part of Group 1. I've been asked just to comment from an HCSS perspective as a community provider. So we see better outcomes for people who are referred early. It may be a referral directly from a general practitioner, and our team will do an assessment and determine the number of hours that a person is entitled to. But as a condition deteriorates, we have the ability to flex up and work with the DSL to, if it gets, or when it gets to a point that the person requires a more in-depth assessment, and at that point they become a client of Te Whatu Ora rather than directly managed by the provider. We have a limit as to how many hours we can put in place as a provider, but once that's exceeded, we can still put that additional care in place, but contact the funder who would back pay us to that requested assessment time, if that makes sense.
Another theme that came up in our discussion in all of the topic areas was about technology, and there were a number of technology-related issues that came up. Generally, I think the view is that there isn't much technology that currently exists that is focused on helping people live independently and well in the community. So we didn't focus too much on the technology that might help providers and the system join up, except acknowledging that that would be a good thing. But we were focused on what might help people to be able to live well. And we think that that is an opportunity, but an area where there aren't a lot of current technologies and applications available. And we also recognise that there is a generational issue, particularly for the old. There are issues around the digital divide and also rural connectivity that need to be taken into account. So it's not, it's definitely needs to be in the mix. But at its core, dementia services are about people and access to services. So the technology needs to recognise that, I guess.
Yeah, technology for technology's sake never did anybody any good, in my personal experience. But we talked a bit in our group about technical literacy of carers and things like that, and and making sure that we're able to support the people, supporting the people, and making sure that they're connected. But that there are some real challenges with that in our very diverse and not cell phone covered country, and making sure that those things are taken into account when we think about how technology can be an enabler in this way. Prudence, I thought you were going to say something there. You leaned in.
I was also going to say I missed a couple of other themes that I should include as well. There's in our group, there was a consistent theme about the lack of cultural inclusion in our models of care. We need more models of care. Maori and Pacific need their own models, and there's a lot of barriers to Maori and Pacific, and of course, if we know right now that less Maori and Pacific use ARC, then no, we are far from any ideal of an ARC model, and that aged residential care really needs to be thought about differently. And then the same thing came again when it came to respite care and our respite caregivers in the Pacific community. That really needs to be responsive, and resources need to be given to a Pacific model of respite. But even, there was talk about different models of care for different age groups inside the aging population, because we have ARC systems that aren't, the culture and environment inside them aren't suitable for people with early onset dementia. People younger just don't find themselves happy and aging well in these environments. So more models of care, more diverse models of care, and certainly some ethnic models of care. That was a theme constantly throughout.
I'd like to pick that up from group one as well. Those themes around flexibility, around diversity, around a range of different services that meet both carers' needs and people living with dementia. Respite being an example where there isn't anything to suggest that you have to have one or the other, that you could be offering stimulating, cognitively challenging, interesting experiences for people with dementia at the same time as you are offering some respite for their care partner. So across all of the areas, in fact, the themes were around more flexibility, more integration, and more
of a view of dementia across all of the stages, i.e. not the end stage only, but from the point of any change and support to get diagnosis through to living well in the community for as long as possible, through to needing to access all sorts of different care options. So that's probably the take home across all of our discussion.
I'd just like to add to that from Breakout Room 5. We totally agree with everything that's just been said. One of our things was that diversity of different groups with dementia and their carers. We also, because 2 of us have an interest in young onset dementia from lived experience, we also, like Daryl just said, need support at the pre-diagnosed stage. We talked about within that model of care, we actually have to understand mild cognitive impairment and actually start to put the supports in place before then, before a diagnosis of dementia. We also think there needs to be significantly increased funding of organisations working in this space. We talked about, we have a couple of lead organisations in New Zealand, and Dementia New Zealand, and Catherine, you'll love this, Alzheimer's New Zealand, who are crying out for this. As a network, we're asking for the action plan, the Dementia Mate Wareware action plan, to be fully funded. I might be dreaming, it might be a pipe dream, but it can be done. But we also have to make sure we look after our informal care workforce, because if we don't, the whole system's is going to just basically implode if it hasn't already. The system is broken. There's a lot of connected parts. But we also come back to that very early model that Andy shared. We just do not think it works for dementia care, whether it be in aged residential care or living in the communities. So we would encourage you to have a look at that model and think about what it actually means in that journey from I don't have dementia through to end of life for those living with dementia and the carers. That be both within aged residential care settings. We also need to think wider than the health system to bring in things like the social care sector, the social Ministry of Social Development, etc. We also have to think about things like wider systems and how the dementia sector system interacts with those systems, not just the health system. That's probably way without outside the remit of this particular session. But until we actually start to connect up all the different systems and actually understand where it's broken and what might work, both on an individual basis, right through to a national basis, local and regional, and what's actually out there already, and we don't even know that. What we're basically doing is saying, this is what we need, but we are skeptical about, can we actually get the resources in place to actually do the ideal? And that's enough from me, because I'm actually getting onto my own high horse.
No, it's good though, and I think these themes of interconnectivity and thinking about the unique, they are unique needs of our folks living with dementia are adequately supported and flexibly supported with the diversity of care in the model is an outcome we want to achieve. So we just need to figure out what are the best ways to close some of those gaps. Chris, you've had your hand up for a long time, and I would love to hear from you.
No, it's Vanessa. I'm with Chris here, but
okay.
Hi, I just want to say I attended this a couple of weeks ago, and something that really stood out, and just with regards to what Paul was saying there before, was the opportunity to look at the stigma around dementia in terms of what came up a few weeks ago was what they're doing in Scotland in terms of school children and educating school children and communities around how living well with dementia is, and how we can support and change the stigmatism associated with looking at the younger generation. And I guess in another aspect too, in terms of the digital engagement, that is something that children or younger people that may be living with someone with dementia may be able to really support that person as well. So it's really, using that sort of the generations coming to support the understanding of dementia.
Yeah. Yeah, I think that's great, and actually builds on one of the things that came up quite a lot in room 6. And I might call on Caroline to talk a little bit about this, but we were talking a lot about preventative interventions and things like that earlier on in the GP context, in that educational context, before someone even gets that diagnosis. And how do we enable those things, access to those things earlier on, which I thought was really interesting. I don't know if you want to comment any more about that, Caroline.
I was hoping to escape it, Kelsey, but you
no.
Yeah, well, we were talking about the importance of primary and secondary prevention. We talk a lot about the importance of diagnosis, but actually there's a whole pathway of evidence and research around how we get to people much, much earlier on. There's 12 modifiable risk factors that the Lancet Commission reported on, and there are lots of specific interventions for people with mild cognitive impairment. So whilst we're kind of firefighting and talking, which of course is really important that people with dementia get diagnosis, we also need to be looking upstream quite significantly.
Yeah.
Thanks. That is a great summary. I think we're getting close to time, and I want to kind of ask maybe one more question to the groups, and I'll phrase it in this way. Are there some promising ideas, opportunities, or solutions, or things that you've seen maybe work in small pockets that we want to that we think we might be able to scale with some support? And I would love to hear some of those from your groups, if there were any. Paul, you can go first.
Yeah, look, I'm not that well connected always with different organisations, but some of the things I have seen working well that have been discussed in the network meetings before, and again, I'm riding my own horse here because of young onset dementia, but what Dementia Canterbury is actually doing with their young onset dementia is a fantastic model. There's also been the $12 million funding. A lot of that comes into great ideas. But how do we get these nationwide? How do we get the best practices into every private setting? How do we educate our informal carers? So, there are amazing stories out there that I've heard just through there. But until we actually start to coordinate them and share them and look at, as others have said, the evidence from overseas, etc., nothing's going to change.
Catherine.
Have I put it down? Yes. Thank you. I think the thing that came up consistently in our group around where the opportunity lies is in that front end, very much in that getting it right at the beginning, and how critical navigation is to that part of the process. And in thinking about the models that work, I would make 2 points. Firstly, the Dementia Mate Wareware Action Plan is evidence-based. So we wrote that exactly for this purpose, and it covers all of the things that we've talked about. And the second thing I would say in terms of New Zealand operating models for commissioning and thinking about how that might work in a whānau focused way, I think Whatu Ora is the place to look.
Thank you. Kristen.
I'll just go through the bullet points I've got here for just some ideas. So one was around technology. So Te Whatu Ora can send an electronic note to a GP, but they can't receive info back from a GP. So it would be great if that communication was two-way. Technology so that if you're getting a visit, you can actually have the technology to see when the support worker is going to visit you. So you see that little, like when you're getting your takeaways, you can see the little thing coming towards you. Why not when you're getting your support worker? When it's just patient empowerment. But this is one that hasn't been discussed. Invest in after hours services. So we had one person who was a paramedic saying that they get called into ARC facilities after hours because there's no overnight care. So the 9 to 5 primary care model, it doesn't work for everybody. And also for carers, supporters trying to get to a GP when they're working. So do they have to take time off work? So just maybe expanding the hours of the system. One person shared about that her experience in the UK with her father was that couple, the wife was able to stay at home because the husband had one person advocating for him the whole time. And finally, I thought this was a very cool idea. Make respite like a stay in a rehab unit. So instead of is it just you're biding away your time, when you go there, you've got allied health input, you go home, you have a plan that you take away, and the advantage of that was that you get all the allied health services in the one space. So kind of rethink respite and make it actually an opportunity for someone to receive good care that will enable them when they go back home. That's it from group 2. Thank you.
That's great. All great things. Thank you, Kristen. Prudence.
Yeah, great points. And our group definitely would second lots of what Kristen was just saying. In topic 1, there was lots of discussion and nodding around the idea of one national technical platform for people with dementia, for all of the sectors, parts and players can access and inform and contribute to, and then presented well so that the clients and users can engage meaningfully with that to enhance their self-determination, which is part of the ideal statement. Jumping to topic 4, the solution really is an education program for our primary care, for our GPs, for our pharmacists around dementia. Education is just really key there because patients hide it so well. So GPs, under such time pressures now, they haven't got the time or the resources to diagnose properly, and assessments are often influenced by family members there as well, or done when a patient is presenting with an acute unwellness rather than at baseline or when they're just living a normal life. So there needs to be more education, an education program was the solution spotted for topic 4. When it came to respite care, the solution was just really around more provision, more funding, more understanding and acknowledgement from the funder to the providers around caring for the carers, because they're overwhelmed. I mean, it was just unanimous amongst those of us in the group. They're overwhelmed. They're stressed to the max. They're losing sleep, and was it Christian that just said about families? Some families need breaks overnight, and this isn't funded adequately at all. And so some providers are sort of coming up with innovations that just are completely under-resourced. I've lost my solution for topic 2, but if I come back to it, I'll come back to me if I find it.
one of the main things that we talked about too was getting back to this flexibility of funding. In particular, maybe because it's a hot button topic at the moment, what's happened with Whaikaha and their funding, especially around carer support. And I recognise that it's the Ministry of Health, a different ministry funding stream for this. But we talked about that flexibility, and one of our participants gave a great example. They hire a gardener for 4 hours a week. And you go, huh? And that is the gardener works with the person living with dementia because they love gardening. The gardener also brings along the dog, so they play with the dog for 2 hours. So now we've got pet therapy as well thrown in there. And it means the informal carer has a break. I could not imagine that going down very well as carer support, but it's justified. And absolutely we have to have in these funding models the flexibility to allow people to think outside the square. We also talked ad infinitum about there just isn't enough funding. The standard contracts for care and the dementia add-on that we have, they're very minimal. They're not aspirational, and the funding itself is not aspirational to improve. So one of the things we think around the funding models for individualised care and also within aged residential care settings is there needs to be an incentive for that. And we also need to incentivise the professional workforce in aged residential care settings to actually participate in that, trying to get aged residential care registered nurses, activities coordinators, physiotherapists, healthcare assistants, etc., to work in dementia is just not there. The whole and we have to incentivise that. And that again goes to a wider system, pay equity for people in those settings with people that work outside those settings, such as registered nurses in secondary care settings, health settings.
Yeah. I think again, it highlights how much the need for innovation and flexibility is really key in this model going forward, as well as making sure we understand all the interdependencies, because it is a very complex and integrated system and not just individual elements of care in silos. I'm mindful that we are almost out of time. I know, Catherine, you have your hand up, but I was going to kick it over to Andy to talk about next steps. Is there something really quick you wanted to add, Catherine, or is can we hand it over to Andy?
No, very, very quickly, just because it hasn't come up directly, although very nice segue from Paul's comments. Just in terms of carers, one of the things that we discussed that hasn't been raised is that carers need to be recognised as a client in their own right, have their own assessment, have their own planning, because they're currently treated as an add-on to the person with dementia, and that means that their services are not necessarily targeted at their needs. And so, yeah, just making that point.
Thanks. Andy, you can speak through mine maybe, and we'll do that.
I'll just do that. Look, I just want to thank everybody for putting aside 2 hours on their busy day and acknowledge the wonderful discussions. I mean, the key things I thought it'd be useful for me to reflect back to you. I hear what you're saying around the model didn't highlight the early stage well enough, and the care that's available both in terms of community support and early diagnostics, and how we get people into the system early on, because I think that's that is opaque in some parts of our system. The use of allied healthcare providers in ARC facilities and in home facilities as well. And then I think absolutely hear you, Paul and Vanessa and Kristen, around making sure we've got people at the centre when we're designing this. I do agree that we need a greater flexibility of services, especially around that early diagnostic and support services. And again, for me, I think this is your other point you're bringing forward, and I completely agree, is how do we actually design the whole system? And when you start to think like that, you start to then understand the complexity of the things that we need to deal with as we take this forward. But I think there are really good opportunities for us in terms of how we manage access to primary care, because I also agree with you, part of the challenge for a lot of people, both in terms of supporting carers and supporting clinicians, is making sure we've got really good access to primary care services and good medicines management as well. I agree the technology aspect, and part of that is us getting things sorted on our side of the fence, because I would love to be able to show individuals and their whānau where they are in the system. I'd love to be able to share more broadly some of the inter-eye assessment information we have, so people could see the types of services they're eligible for. And in a perfect world, it'd be great for me as a son and a son-in-law to be able to see when care has actually turned up to my parents or parents-in-law when I'm in Wellington and they're in a completely different town, and be on top of that sort of stuff. And if we invest in the right types of technology, then that's all possible, and that creates a greater sense of trust and surety in the system. But they are the sorts of things that I want to get through this process, so we can actually prioritise those and invest with them as well. We've got another month's worth of consultations. I think we've got 8 face-to-face sessions planned, an online session, and there'll also be a questionnaire available through our website for people to complete. They can go through an information pack and give us individual feedback. So I'm fully expecting that will come through some of your team as well. And then, I think over June we'll be mainly synthesizing that, but my general operating approach is to try and share that as much as I can and be relatively transparent about where we're going with all of that. And I know with the leadership groups we've got around dementia that we'll be talking to you through that format as well, and then we'll be able to have some content that you can share back out with your networks. I think will be really important. And then we're moving through that process into by the end of August, the plan is to have a business case that talks about how we set the system up and where we need to invest in over what sort of time period. And then at that stage, the way these things work, it becomes more opaque around the exact numbers and the trade-offs that funders and the government might have over time. But I'm fully expecting there's a whole lot of stuff that we can crack on with within our current funding and models of care. And some of the stuff that you've talked about already, I just want to give some assurance that we're already starting to progress. So moving to bulk funding restorative care models is already underway. I've got a planning session on Friday with the Hospital and Specialist Services Group around how we might use the allied health and district nursing resources to focus more on people in the community and in ARC settings and people with home community support, because I understand that that's incredibly variable across the country. And so we will carry on focusing on those sorts of things as we work through this broader business case. So that's sort of a bit of a summary and next steps.
We've got Teresa, who is our chair, who will close the meeting for us.
Oh, kia ora. So thank you, Andy, for that, for giving us a synopsis of next steps. And it was a very interesting listening to all the comments and whatnot, and I hope that people felt that they got their views across and that it will be captured and help inform the work that Andy and his team are doing. So thank you very much. So the next network meeting is on the 13th of June. So I'll just, without any further ado, I'll just close our meeting. So Unahia ki te urutapu nui a tāne. Kia wātea, kia māma, te ngākau, te hinengaro, te tinana, te wairua I te ara tangata. Koe a rā e rongo, kua wātea, ai rā, kua wātea. E rongo, whakairia hia ake ki runga kia tina, tina. Haumie, huie, taike. Ka kite.
Yeah.